afternoon, everyone. This is Midweek Vibes, our midweek show that brings issues that concerns us most, and we have professionals all the time to help us expound on them. And we are privileged today to be discussing fertility, an issue that is at the heart of every person, because we know we are always concerned about whether we're going to get children or not, how those children are going to be like, who is going to lead this country in the coming generations. So it's an important question, so we have paid attention to it. And with me today is Dr. Muriuki, and he's not new with us. Karibu sana daktari.
Asante.
Please tell us more about yourself, especially as far as women fertility issues are concerned.
Asante sana. My name is Muriuki Charles, and I'm privileged to be here with you. I am a gynecologist by profession. Yes, so I think fertility is one of those issues that, we always have varied discussions about, and will always be a sensitive issue. And I think maybe you could just, go ahead and just describe what it is, or infertility, what is infertility is.
Yes.
So generally would say infertility is a condition where a couple has been trying for at least 12 months without any success in getting pregnant. And this is with a caveat of age, if they're less than 35. But if the woman is more than 35 years of age, then would say that 6 months is where I would say the cutoff is. So if they're more than 35 years of age, then and they've been trying for more than 6 months, then would say that there's an issue there of fertility. Yes.
Wow, that's a good one. So the other side of the coin is that fertility is ability.
Yes.
To conceive, or to get
yes,
pregnant.
to get pregnant, yeah.
Yeah. So are there factors that really contribute to infertility, or to even to fertility itself?
Yes, so generally would speak and say that several conditions can, contribute to that. And I'd probably approximate and say 1 out of 7 and 1 out of 10 couples would have this challenge. Of getting pregnant.
Oh, okay.
When we look at the factors, there would be factors on the woman and the factors on the man. For the woman, the commonest in our context would be the fallopian tubes having a blockage, and that would prevent the egg that is released during ovulation being able to meet with the sperm and allowing the fertilization to happen. The other factor that would contribute is factors that would affect the ovary. So we usually would say 95% or 9 out of 10 women who have regular periods or regular cycles are ovulating. So that conversely, that means that if there are irregular periods, that means there is some form of hormonal imbalance, and that means there is a possibility of lack of ovulation. So that lack of ovulation can be caused by several things. It can be caused by hormonal imbalance due to a condition in the ovaries called polycystic ovaries. It could also be caused by a thyroid issue. Okay, or conditions that would be affected in the brain that would make the signals from the brain to the ovary not function properly. And of course, some of these things are not discussed. Something like weight, because an elevated or increased BMI, weight does contribute to excess estrogen and contribute to the lack of ovulation. So weight does also play a role, yes. Yes.
Excess. How about less weight?
So less weight can also be, a factor. You'd be very surprised to know that women who are excessively active in sports, and this is common in women or female athletes, they actually don't have their periods, they don't ovulate, because the body is driven to a point where it doesn't function properly because of the excess physical activity or strenuous exercise. So there is a balance.
There's a balance.
Yes.
Oh, that's a good one. That's a good question. Maybe you can question us directly.
Yes. So, but most of the times you'd find in our context, the converse of inactivity is more common. So you'd find that people are not as active. And we usually say, especially for people who might have a condition like polycystic ovarian disease or ovarian syndrome, we'd recommend, diet and exercise as the first line of management. So diet and exercise for 6 months, and if women even lose like 5% of their weight, that they can go back to regular cycles.
Oh, that is so good. So the first line of intervention
in the polycystic ovarian disease is actually diet and exercise.
Is diet and exercise.
The only challenge is that in our setting, we have lived in a microwave age, so people want a quick fix. They want to have a tablet that will sort out everything. But yet we know not only are we solving an issue of ovulation by losing weight, it also has added benefits to the human body. I mean, we're also reducing the risk of diabetes, reducing the risk of hypertension, and even the strain on the bones and the ligaments. So weight reduction does have more benefits than just ovulation.
Wow, that's a good one. Now, when we talk about those things you mentioned, weight, diabetes, you mentioned it there. Are there other things, like is smoking a key issue? Does it affect fertility?
Yeah, so smoking can affect the fertility, but mainly in men, because smoking does affect the quality of the sperms. So it does affect the quality of the sperm and even ability for it to move.
Okay.
Alongside, other recreation, we call them recreational substances, hard drugs, cocaine, even Mira itself can affect sperm function.
And how about alcohol?
Alcohol, probably would say excessive use of alcohol does also impair the sperm function.
Oh, that's major. That's huge.
Yeah, it's important that is not highlighted as much because I think in our context sometimes fertility is looked at as a woman's problem, or infertility is looked at as a woman's problem, as opposed to, and yet we know 1 out of 3 couples trying to get pregnant, the challenge actually is the sperms.
Oh, really?
Yes.
1 out of 3?
1 out of 3.
That's huge. And that's a society, it's a cultural issue here, because it's true. Most women are expected to be able to bear a child.
Yes.
And the finger is never pointed at the men.
Yeah, that's true. And yet we know 1 out of 3.
I think hearing it from a doctor, a medical point of view, that is huge. It's really nice to know that women are not to blame.
Yes.
Not that men are also to blame all the time, but it's good to have that balanced view.
Yes.
Yeah.
So what we say is actually a couple's challenge. So we need to address the issue as a couple, as opposed to one partner and not the other.
And women have suffered a lot.
Very true.
Yeah.
There's a lot of bias. I agree.
So I think it's how you hear someone being preached and you feel like somebody else should be hearing it. Even right now I'm thinking, I think more men should be hearing this so that they can be more compassionate, more gracious when there's an issue in the family of childbirth, not childbirth, of conception or fertility. That's really nice. I'm glad you talked about that. Now, you talked about age, and you said that women 35 and below are more likely to be more fertile. Did you say that?
Yes.
Than older women?
Yes.
What happens to a woman when she passes the age of 35?
So 35 is not a magic number. It's just simply saying that when you look at fertility, the most important success or predictor is a woman's age. So the younger a woman is, the easier we would look at it and say they are likely to get pregnant. And we also know that generally the eggs tend to, the quality of the eggs and the number of the eggs tend to show a decline, a steady decline from age 35.
A steady?
Yes. So that means that a woman who is more than or greater than 35 years of age would take longer to get pregnant than one who is less than 35. So again, these are factors that are not within our control. Again, society has, with the times are changing. There is more advent of education. Women want to further their education before they settle down in life. Sometimes there is the reality that maybe a suitable partner is not there yet, so it's not really within their control. So there is a tendency to finish education, further education, and then probably consider family. And that might have some effect in the sense that by the time they settle down and maybe having 1 or 2 masters, they might they may be catching up with their fertility, and they might need a bit more time or more interventions to get pregnant. Yes.
Wow, that makes a lot of sense. But these days, I see couples wanting to wait a little longer. They get married, they want to spend a little more time. The couples usually will say they need to spend more time to know one another.
Yes, and sometimes these are factors that you might not be able to quite control. But there are times when you would, find for one reason or the other, evaluate a couple, and you might find one or two issues and advice. For instance, as we were talking about last time, a disease like endometriosis.
Yes.
Because endometriosis can actually damage the tubes and also create an environment that's not conducive for pregnancy.
Yes.
So we might actually advise and say, look, by the time you settle down in life, if there's nothing that is actually preventing you from getting children, earlier might be better than later.
Than later.
Yes.
And they can ask me.
Yes.
I got
Earlier
my
may be
kids
better
a
than
little
later.
a bit early.
Okay.
But not because I was very wise.
Yeah.
But as providentially,
Yes.
that did happen. But there is something, I also, because couples want to know one another more, it's a good idea to know one another more.
Yes.
But I always say, I wish couples can know each other better earlier, before marriage, so that they
Yeah.
spend less time
Waiting.
And there are a couple of other things that they may not know can become a problem later.
Yes, yes.
Yeah, but that's not medical. So coming to medical issues, I was just wondering about simple interventions.
Okay.
Not very complicated, especially the one you talked about, like maybe good diet, moderate exercise.
Yes.
I've heard about calculators.
Yes.
What are those?
So basically, when you look at fertility, sometimes, and this is in the context of, let's say, treatment, sometimes based on the condition that might be contributing to the challenge of getting pregnant, if at all it's the, let's say, the fallopian tubes could be blocked, and they could be blocked because of infection or previous surgery that could have affected the fallopian tubes, or surgery on the fallopian tubes, or a condition like endometriosis. Then this is factored into a software that would give an approximate success rate. Of course, as we said, the woman's age is most critical and carries a lot of weight. There could also be, factors regarding how the sperm count and quality is, and the movement of the sperm itself. So all this is factored, and then we get a probability of success, and probability of success most likely when it comes to IVF. So these probabilities give us an idea. The reality is, even when all factors are constant, only 1 out of 3 couples succeed to get pregnant in one cycle or in 1 month.
You're talking about IVF now?
No, this is natural conception.
Oh, natural conception.
Yeah, the assumption is usually that when all factors are constant, people should conceive in 1 month, which is not true. So 1 out of 3 couples will get pregnant in one given cycle or 1 month.
Oh, okay.
Yeah.
Interesting.
The rest, the 2 out of 3 will need more time. And there's nothing wrong with that.
It's okay.
There's nothing wrong with them.
nothing
That's why
has
we
gone
say
wrong.
actually we need to give time for at least 1 year if somebody's less than 35.
Yeah.
Because most people will tend to conceive, even if they've not conceived within 6 months, the next 6 months, 85% would have conceived by 1 year. Yes.
Yeah. That's very assuring to young couples especially.
Yes.
That you don't have to beat yourself
Yeah, you don't have to beat yourself too hard.
too much. Yeah.
Yes. So diet and exercise, both for the both partners. Actually, for men, diet and exercise also that weight reduction actually does contribute to better sperm quality, and that has been shown by research. Again, we have emphasized the need to consider age, and especially those who might have other conditions that age will also be contributing in a negative way. Again, some of these things are beyond us. You might not necessarily reduce your age for that reason. The other thing is also social factors. I mean, the society is changing, and you might find that for one reason or the other, people are married, but they don't stay together. To the extent that when we ask questions, we don't ask, are you married? We ask, do you stay together?
Oh, right.
Because being married and staying together is not synonymous. One could be working in Mombasa, and the other person is working in Kisumu, and they only visit twice a year.
Yeah.
So that naturally would affect
Yes, indeed.
fertility. Yes.
Yeah.
So some of this is really not scientific. It's actually social factors.
It's social factors.
Yes.
Wow. I felt a little concerned about a young woman right now, because we spoke a little earlier about this, that at birth, and you collected me, and I want you to collect me here so that we can all get the correct understanding, is that there's a reservoir.
Yes.
A girl is born with a reservoir of the number of eggs that you have through her life cycle.
Yes.
So talk about that a little bit.
Yeah, so it's just about numbers. Sometimes we've never thought about it, yes. But a female baby, we call it a female fetus,
Yes.
Would have 3 million eggs in the ovary. By the time that baby girl is being born, it's around 300,000.
Wow, the reduction is, I can't.
That's just natural.
Natural.
Yes. Yeah, there's nothing wrong with that.
There's
it's
nothing
just,
wrong.
It's
It's
just
the way
how
things
it
are.
is. Yeah.
So she'll be born with 300,000.
Yeah, and this is because of the natural way the body tends to handle cells that are not being used.
Okay.
By the time they get to having their first menstrual cycle, thereabouts, again, there's a further reduction, maybe to around 100,000. So that is where we started. And that's why, as you can see with time, there's a reduction. Because with every cycle, there's maybe around 10 to 12 eggs are recruited.
Oh, really?
And so they are always deducted from that 100,000, if you were to think about it theoretically.
So it's like a bank account?
It's like a bank account that
and you're always withdrawing.
And you're always withdrawing, but there's no way you can deposit.
You can't deposit.
You can't deposit.
Wow.
Yeah, so that's why age becomes a factor.
A factor.
Yes.
Yeah. Wow. But not all women will reduce at the same rate, right?
Not all women reduce at the same rate, and this is mainly influenced by their genes.
Okay.
Sometimes you'd actually ask, if they do remember the age at which their parents, or mainly their mother, went into menopause. So if they took a little more time, because the average age is 50, so if they went into menopause way earlier, then there's a high likelihood that they might actually have a depletion of their eggs, because menopause technically is a depletion of those eggs.
So that's so important. So you're saying, if our parents, for example, if my mom started her menses when she was young, then
and went into menopause earlier, then there's a probability that
I, for example, I'm the child, I start my menses a little earlier, then I'll get my menopause a little earlier. That's how it goes.
Yes, there's a genetic component. It's not always absolute, but there's a genetic component.
It should be taken into account.
It should be taken into account. But we don't always factor in, because at that point in time, you're also assessing what other condition or what other factors
are
seen.
An isolated factor.
Yes, and sometimes actually we also know that in 1 out of 4 couples, you may not find any particular reason why they're having a challenge to get pregnant.
Oh, none whatsoever.
Yeah, and it's almost like 1 out of 10 to 1 out of 1 out of 4. So, and we also know that 2 out of 3 couples, there might be a challenge in both partners.
Right.
So the only challenge is actually sometimes people think it's one partner that has a problem or a challenge, and actually they might actually be factors in both partners. There might be challenges that you need to address in the male and the female. Yeah.
Wow. Is this a reasonable question?
Yes.
Is there a way to forestall, like for example, if I know my mom stopped her menses very early, and I'm at a risk, apart from getting children, is there I can do something? Can I do something about it? Can I have, can I put a pause to menses?
No, you can't quite put a pause. But as regards fertility, what I've seen is that, and this is something that's quickly evolving in our context as well, women might feel that given my age, I might not be able to, my mindset is not at the place where I want to settle down. So some women do actually have what we call banks for their eggs.
Okay.
So they actually do have a situation where, they do see a doctor, where the doctor actually gets some eggs from the ovary, and these are frozen.
Okay.
Frozen in the sense that they can be used later if at all age becomes detrimental, they can be able to go to the bank in the ovary, we call it, withdraw the eggs that they had frozen.
Yes.
So they actually freeze the eggs at that point in time, so they stop growing.
Yes.
So they don't have the chronological age of the woman.
Exactly.
Yes, so that happens, but again, it comes with an extra cost, and it may not be accessible to many.
So it's not popular?
It's not that popular, again, because cost is prohibitive.
Because it's a huge concern. Wow, that's pretty nice. So now, when we talk about pregnancy for older women, are there things women should be concerned about? For example, is the quality of the egg an issue?
Yes, it is. So, unfortunately, these are things that we might not have had, clear time to discuss. But generally, number one, so it does take longer to get pregnant for a woman who might be older than 35. So there might be a time factor in terms of getting pregnant. The other unfortunate thing is that there is also a high likelihood of a miscarriage compared to women who are less than 35. And because of the age effect on the egg, there is a slightly higher chance of having a genetic issue. So women who are above 35, we always say that they might need a bit more close monitoring. Sometimes we encourage them, and nowadays all women who are pregnant, they need to have a scan between 11 and 13 weeks just to see if there's any suggestion on the scan that might point to a genetic issue. There are actually blood tests that can be done to confirm if there's any genetic issue that might affect the survival of the fetus, or outcome of the fetus. Yes. Wow.
So there are two things I would like us to look at much more keenly. One is miscarriages. The other one is the testing. Let me ask the test first. Can a test be done on a woman to know the reservoir, how many eggs are remaining? And
yes.
Should be given advice on that.
Yes, actually there's a test, and it's called an AMH, or anti-Mullerian hormone test. Basically what it does is to look at the ovarian reserve. So there's a reserve, and confirm what capacity is left in this reserve. I mean, there are also other tests like FSH that look at the capacity of and the functioning of the ovary. Because the ovary, the way God designed us is that the ovary does give feedback to the brain to tell us, this hormone is required and this amount of hormone is required to release an egg. So the higher the amount of hormone required, then that points to the fact that the ovary is not functioning well. But the AMH tends to go down with age. So that can give us an idea and help us know, number one, is fertility likely to have an issue, to be an issue? And even for those who are seeking treatment, what is the likely effect? Might we need a higher dose of, let's say, injections to stimulate the ovary as compared to somebody who might have a higher value of that? So there is that test.
Fantastic. That's very good. Thank you so much, Dr. Harry. I think we'll take a short break. And when we come back, we'll look at miscarriages. And another possible treatments for a couple that is trying to get pregnant. So don't go away. We'll be right back.
Oh, Father Lord, such an amazing love you love us with. Oh, it's an amazing love, unending gratitude. You gave your son, Jesus, so that whoever believes thirsty, come all who are weary. You don't need no currency, come buy, eat, because Jesus has carried all of our sin. He paid our debt and full for death and damnation. It's an amazing love, our Father Lord, He sent His Son, Jesus, to the earth, so that whoever believes in Him, yeah, will not perish, but have everlasting life. And only one truth, there is only one way, and one spirit, only one sacrifice, and Jesus is the truth. So Jesus is the way, He is the sacrifice given once for us. An amazing love. Our Father gave His Son, Jesus, to the earth, so that whoever believes in Him doesn't have to perish, but has everlasting.
Welcome back. It's so nice that you've been with us, and we have been discussing, you are joining us right now. We are talking about the whole issue of fertility, and Dr. Muriuki is here with us, and he has done a super job of explaining. So make sure you go back to the beginning of the video to ensure you benefit fully from this conversation. So we wanted to pick up the conversation from where we stopped, and we want to pick up
Yes.
at miscarriages.
Yes.
Let's talk about what causes miscarriage.
Okay.
Is there a factor in infertility?
Yes, actually, I mean, if you were to look at the strict definition by WHO, they'd also say that even women who have had miscarriages basically not have a baby. They've not been able to carry a pregnancy to term and have a live baby, that they will still be categorized in the stricter definition of infertility. But we don't use the term infertility because technically that sometimes tends to be hurtful. So yes, miscarriages do happen. They're actually common. The reality is that women might have had miscarriages, but for one reason or the other, they might not have known. Maybe they missed their periods 1 month, and the next month, their periods came, what they think was their periods was a miscarriage, but it came out, you know, heavy. But actually that could have been a miscarriage. So, and then the other reality is not everyone does talk about their miscarriages. And that because the pregnancy was not obvious. So we know that even though a woman has had a miscarriage, doesn't mean that they are less likely to carry a pregnancy. So granted, most of the miscarriages are spontaneous, call them spontaneous, sporadic, and they could be unexplained. But we also look at miscarriages in the context of what could cause it. So the commonest cause of the ones that we know, because the commonest cause is a genetic issue, and this is let's say in 6 to 7 out of 10. There could be a genetic issue in the makeup of the baby. So the way the genes of both partners, the man and the woman, once the genes come together, there could be a genetic issue that causes a genetic mismatch. And that means that generally, if there's a genetic mismatch that's not compatible with life, so the pregnancy will not continue.
And that's a natural way.
That's just the way nature of the body not rejecting something that's not consistent with the correct genes in the human life.
That's a good thing, certainly.
Yes. Yeah. So that genetic effect could be one of sporadic and not recurring, but in some people who especially have had 2 or more miscarriages, sometimes say 3 or more miscarriages, we might need to investigate, run genetic tests on both parents to find out could there be a gene that is repeatedly presenting itself and causing a miscarriage. And we're talking about couples who have never had a pregnancy carried to term. Okay, so there's a genetic component. Of course, the other factors that can cause a miscarriage, for instance, if there's an issue with the with the uterus. So for one reason or the other, maybe the uterus does not have the correct configuration, or if the cervix is not functioning properly to be able to hold and prevent and maintain the competency of the cervix. Or environmental factors.
Yes. The competence. Let me repeat that. The competence of the uterus.
Yes.
So that's the ability of the uterus to hold the baby inside?
To hold the pregnancy. So because sometimes we and this is sad because the terms that are used that are not friendly, because it's not a woman's fault. There's nothing that she has done or failed to do that causes a sporadic miscarriage. But there's a tendency for especially a woman to feel, is there something that I did wrong to cause this? Was I not careful as a mother? Was I irresponsible? And that's not true. I mean, sometimes people have been told, maybe you've been carrying too much weight, or maybe you're stressed, or maybe you're overworking. Generally, if you ask Kenyans whether they are stressed, 90% of them will tell you they are stressed. But stress does not contribute to a miscarriage.
Oh, really?
Yes.
That's a good one to note.
Yeah, emotional stress doesn't. I mean, if this was the case and our grandparents who were carrying huge, mtungis of water, then they must have been, should have gotten many miscarriages, which is not true. So generally, we always look at it and say, let's be objective and scientific and say, yes, it's not stress that causes that. So unfortunately, it's very difficult to tell a couple that, look, there's a miscarriage that happened. We've done all the tests. We've looked at the uterus. We've looked at the cervix. We've done, genetic tests on the baby. We've done genetic tests on the parents, and we can't find a cause. Sometimes there are blood tests that we run to find out, could there be antibodies in the woman's blood that might be fighting the pregnancy or causing the blood to clot in the tissues that support the pregnancy, and that causes a miscarriage. These are also tests that can be done. So these tests are not cheap as well. That's the other sad thing, because if somebody has had 2 or 3 miscarriages and to run these tests, usually comes to around 50 to 80,000 Kenya shillings. And that has not solved the problem yet. It's just getting to know what could be the issue.
Right.
Yes.
Wow. So when a couple presents themselves with an issue of miscarriage, so basically you sit them down. Do you pre-counsel them before you do the test? Is that done usually?
Yes, we have to pre-counsel them. Remembering that also they are grieving because it's a loss, just like any other. So we also have to, have grief counseling for them, just to know that yes, they are going through grief and have to be counseled and accept and be able to know, do they need time before we do any tests? Are there tests that we need to do prior to trying again? And there are tests that we would recommend to carry out depending on what could have caused a miscarriage and what we have found out in the history. Of course, other conditions like diabetes, thyroid disease also need to be evaluated because this could be subtle contributors to fertility and miscarriages as well. Yes.
Wow. So normally after you have done the evaluation, you have done the testing, the pre-counseling, the waiting period has come. What's normally is the recovery rate?
Yes, so actually, and again, there's the time. The time is really not, we don't specify any time. Research does not, give us a specific time frame within which a couple should try again. I've had this before that people are told to wait for 3 months, others 6 months, other one year, and that's not based on any evidence. We usually would say once a couple feel comfortable to try again.
You leave it to the couple.
Yes. So there's no time frame. Again, we know that women who've had a miscarriage tend to have a higher chance of a miscarriage compared to women who have not had a miscarriage. That does not mean that they will definitely have a miscarriage.
Right.
But we do put them on some, hormonal support or boost to ensure that, we reduce the chance of a miscarriage.
Wow.
But again, as we all know, there's no guarantee. It's only God who can actually guarantee this.
That is true. But from a medical point of view, and being a gynecologist, have you seen progressive stoppage once you understand the situation, so there are no more miscarriages and the baby is able to be carried to term? Yes,
actually we've seen that, to be able to know what could be the trigger and address it. There are some people who actually might need beyond just the hormonal support. They might need injections of blood thinners to prevent the blood from clotting.
Yeah.
So there are interventions that we can institute, and also depends on what the cause is. Again, to also prevent that fear and anxiety of a repeat, and actually that happening also is just more, it becomes harder with time.
Yeah.
So if you can be able to find out what is causing it and address it early on, the better.
Wow, thank you so much, Dr. for clarifying that. And I think the eases the lot of many women when they know usually it's not your fault.
Yes.
You did not contribute to the situation you're in, because it's already painful.
It's already painful.
It's very painful and difficult. And I think society expects that once you get married, you must get a baby.
Yes.
Once you get pregnant, you must carry the baby to term.
Yes.
Is there something you can say to encourage the communities not to put undue pressure on the young couples or the moms who are not able to carry a baby to term, so that they have a little more compassion? Yeah, you could say something.
And I think that's a very, very important point, because generally I think the assumption is that people should, once they settle down, get married, the next 1 or 2 years we should see babies. And as I said, 1 out of 7 couples will have a challenge. The difficult thing is nobody imagines that they could be the 1 out of 7.
Exactly.
Okay. And it's more prudent to probably not ask when the children are coming, or when the pregnancy will start to show. Just because there's already pressure from within in most couples. Maybe they are still struggling with that.
Yeah.
They might have had a miscarriage and they're still grieving. And I usually find it easier to say it's better to be a friend and celebrate people in the moment that they are at, as opposed to asking them when the children will come and how many they are coming. It's a very difficult space. And I must be honest and say we also have this challenge in the church, because people expect that children should be coming soon, and after 1 there should be 2, then there should be 3. So I think it's important to be sensitive and be compassionate.
Yeah, thank you so much for saying that. And then also parents.
Yes.
Because parents will say there are certain communities that name, give the child is named after the matriarch or the patriarch. For example, my mom could ask me, or a mother can ask, so when are you naming me?
Yes.
Hey, we've been waiting to be named in this family. Hey? So now they mean well. I think they mean well.
Yes.
But to a couple that has a challenge, it can be very hurtful.
It's hurtful, and it's hard. I actually have had patients who have told me that they don't go for Christmas. They would not attend any Christmas function at home, just because the pressure is real. I mean, and it's a reality, because the culture that expects that people must be named, and there's one who actually said, I've had enough struggles. I have siblings. The siblings will give the names to the other. But yes, it's a reality, and this comes just from the whole idea of what I mean. It comes back from marriage, and I think I'll draw from the live and cleave, because if they have not left, then that means there's expectation from parents. Right. And sometimes it may be a difficult space to discuss with their parents about it. I think it might be prudent to probably support rather than weigh in, because maybe it's also it's also the pressure. I think the parents also feel their friends at that age bracket are also being named.
They have been named,
So they also want to be named. I think yes, the society has enough pressure.
No need to add to the couple. But I also think there could be a role parents can play, talking to their own children a little earlier about the possibilities. Because there's no society that doesn't know that there are problems.
Yes.
So I think we can encourage parents to begin to introduce the topic at home, so that sensitivity is built earlier.
Yes. Yeah. And it's true, because the question then becomes, let's say for instance, the treatments don't work. Is adoption an option?
Yes.
Would the parents be comfortable with, adoption? Would the couple be comfortable with adoption? Maybe perhaps by the time people settle down and get married, these are not discussions that they've had. And there are couples who've come and said, look, we've tried, and we would want you to sign for us these papers. We are going to an agency, and we will be vetted to see if you are comfortable enough to adopt. And even they said, look, we have siblings or relatives, you know, who have lost their parents, and the children are very young. They need support. And here we are looking for children, but yet we've opened our eyes. There are children who need parents. So, and I was very moved when they said, we'll just take one of my relatives who lost I mean, they died at a younger age, and there are small children left to adopt and take care of them. So these are not solutions that are based on science, but I think the discussions are difficult within the couple's context and also society, and society means, you know, community and church as well.
Right, it's a morally right decision to consider adoption. I've heard about issues like surrogacy.
Yes.
Is that one of the interventions to infertility?
Yes, so that's one of the interventions to fertility. Basically, a surrogacy basically means the egg is gotten from the woman, and the sperm is put together in the lab, what we call a test tube baby. Once the embryo grows, it's inserted into the uterus, but now of a different woman, probably younger, who may not have any challenges with the configuration of the uterus, maybe that the other, you know, woman might have had. But the egg is, so genetically that baby is genetically carrying the chromosomes of the parents, only that now the uterus is just a different home. The housing is different.
Yes, it's a different home.
Yeah, so that's what surrogacy is all about.
Right. Is that common in Kenya?
It actually is
getting, in the West.
It's gaining traction in our context. I think the other challenge we had in our context is that the laws were not there. So the laws are catching up with the demands and the needs, but surrogacy, yes, it does happen in our context.
Wow. It's a very kind gesture.
It is a kind gesture. So there is women who say, you know, I'll get my sibling or a relative, a close relative to be a surrogate. Some might actually have a contractual agreement with somebody they do not know. And of course, there has to be a legal aspect to that. Yes.
I'm sure the issues there are many.
Yeah.
The moral issues there are many. The legal issues there could be many, but it's a viable option.
It's a viable option, yes.
The other one is the intravenous, the IVF.
Yes.
How is that? Has that one gained traction too in Kenya?
Yeah, so that has gained traction. I think also, just as we said, society is changing. Women are delaying childbearing for reasons that, you know, beyond their control or within their control. And actually, some are actually deciding to get children a bit later. So IVF basically is, you know, where you say and there are women who might have a challenge because of, let's say, for instance, the tubes are blocked, but the eggs are functioning okay.
Yes.
So it's basically bypassing that blockage by getting the egg and putting the sperm and the egg together outside of the human body in the lab, and then now transferring the embryo inside the uterus. So basically that is what IVF is.
So what do that's the I means?
In vitro.
In vitro?
In vitro fertilization.
Fertilization.
Yeah. In vitro means outside of the human body.
Right. And the IV?
Yeah, IVF. So in vitro. In vitro? In vitro fertilization.
That's what it is.
Yes.
So in terms of cost, is it out of reach or is it accessible?
So it's actually out of reach to those who need it the most, unfortunately. Because the average cost is around 550 to around 700,000 per cycle. It's not a guarantee. Per cycle means in one transfer.
Oh, really?
Okay, so again, several tests need to be done to ascertain what is the capacity of the ovary. Depending on the results, we'd either say that a woman will get her own eggs or she might need donation or egg donation. Once the embryos are transferred, that is one cycle. We also know that it's not a guarantee because the success rate even in best centers is 4 out of 10 will go home with a baby.
Wow.
So that means 6 out of 10, despite having spent almost 600 to 700,000 Kenya shillings, will not go home with a baby. And I think that's the other reality that can be quite difficult and hurtful, especially when people expect it to be in the 4 out of 10.
Yeah, because everybody is hopeful.
Yes.
That they'll be among the 4 out of the 10.
The 4 out of 10.
So the other 6 subsequent attempts,
Yes,
they likely
generally would say that the cycles for IVF are recommended at 3 to 6.
3 to 6 cycles.
Yeah,
Okay.
so that means they might need another cycle. And then depending on also what the factors were and seeing what exactly was done differently or should have been done differently to improve the chances of success. But
Yeah.
again, remembering that there has to be tests done prior, and also just like,
Yeah,
you know,
yeah.
these are tests that also need, you know, there are costs, there's a cost element to that. Sometimes they might even need procedures to reconfigure the uterus to the proper configuration. That is ideally a procedure.
Wow.
So it is expensive.
It's
I would say.
expensive.
Yeah, and unfortunately we don't have the support from the NHIF to be able to boost this, which would
Oh, is that
really,
right?
yeah. Again, people don't see it as a sickness. Yes, it is a health concern.
Yeah.
I think we are still in that advent of dealing with diseases that, you know, might kill people. They may not think of this being a condition that needs treatment.
That needs treatment and good address because it affects our society
It does.
and the quality
Yes.
of life of our people.
Yes.
Thank you so much, Daktari. I think we are coming to an end. Thank you so much for amazing information. We have talked about female fertility mostly, or infertility.
Yes.
Is there something you can say about male infertility? So the reservoir, the ovarian reservoir, has a limited number of
Let's say
ovaries.
yes,
Right.
there's basically the number of eggs tends to diminish with time.
With time.
Yes.
How about for men? Do they also get their own reservoir, or is it produced regularly?
They don't have a reservoir that reduces with time, and basically it's just the reality.
Right.
Yeah, but we know that the sperms can be affected either because there's a blockage in the sperms from where they are produced, and that can actually mean that when a test is done that there is no sperms at all, or they actually might be fewer in number, or they actually might be not able to move.
Right.
Okay, so all these tests need to be done to a sperm test is usually done to ascertain what exactly could be the issue. But of course, we did highlight the need to probably look at other factors that could contribute.
Right.
You know, weight could contribute to that, and sometimes smoking,
Other substances.
smoking and taking excessive alcohol.
Yeah.
Some conditions and diseases like diabetes can actually affect, you know, sexual function. That
Right.
actually the nerves are damaged,
Right.
and that might actually affect intimacy.
Yes.
So we'll probably also look and analyze that and optimize the treatments to be able to, you know, help the couple. So male factors are there, much as, you know, society does not seem to pay much attention to that. It's actually not prudent to proceed with an intervention without having assessed the sperm parameters to know whether they are actually normal or not.
Right, yeah. So I think I just love the way you have addressed that part, that the couple both will need to be well assessed
Yes.
before you reach an intervention.
Yes, because we also know in 2 out of 3 couples trying to get pregnant, there's actually a challenge in both partners.
2 out of 3.
Yes, so you might actually be quick to assess one and forget the other,
other.
and then that affects success.
Yes, indeed.
Yes.
Wow. Thank you so much. I think I am the primary beneficiary of this conversation. It's so educative. It's so informative. Thank you so much. You have created a lot of awareness. I don't think there is a couple or even a young person who has listened to you and will not want to do something ahead of time. Are you accessible? Can
Yes, I'm
people come to you?
accessible, yeah, and I could give my number, I think,
Yes, please. Yeah.
for those who'd want,
Yes.
and my email address.
Yeah, please.
Yeah, my number is 0733 287845. That's 0733 287845. And my email address is charles.mariara@gmail.com.
Excellent. Thank you
Yes,
so
so
much.
feel free to reach out,
Yeah.
and we could have more discussion on that.
And the name, once again, is Dr. Muriuki.
Yes, thank you. Yeah.
And he is accessible, he's available, and you can tell he's knowledgeable, and he's very compassionate. I feel you have come to your trade, quote unquote, with good compassion
Thank you.
for couples, and we thank God for you. And Dr. Muriuki is our very own, by the way. He is a Mamlakite, and he is very, very accessible. He's very, very available, and he is there for you. If you have questions, your friends have a question, your relatives have a question, go ahead and listen to the video again and again. But no, that number at the end of the video is there, plus the information that is there so that you can access him. So thank you so much. That's all we have time for, guys. Thank you for staying tuned. We look forward to hearing from you. Today we don't have, it's a recording, so we do not have a chance for you to send questions. But do send your questions to Mamlaka Hill Chapel, info@Mamlaka Hill Chapel, and we shall get to you at some time. Bless you. Merry Christmas. God bless you. May the Lord bless you till we meet again. Bye-bye.